All right, so in this video, we would be focusing on the thyroid gland anatomy and physiology. Kindly support this channel by subscribing, clicking on the like button, and also do well to share content on the channel to family and friends who may find the content very relevant. Now, the thyroid gland anatomy and physiology. Now, the thyroid gland is actually the largest endocrine gland. Okay, this gland weighs about 20 to 25 gram. And just like all other endocrine glands, this gland is highly vascularized, meaning we have a lot of blood vessels around this gland. Okay, it is located anterior to the trachea, that is in front of the trachea, just below the larynx, spanning between the levels of C5 and then T1 vertebrae. So the fifth cervical vertebrae and then the first thoracic vertebrae. In terms of its relationship, it spans between the fifth cervical vertebrae and then the first thoracic vertebrae. In fact, we also call this gland the gland of metabolism. Okay, the gland of metabolism, because this is the gland that is in charge when it comes to metabolic activities. Okay, so anytime activities of this gland increases or this gland is stimulated, metabolic rates would also increase. Okay, so we call this gland the gland of metabolism. Okay, in fact, in terms of its shape, it is butterfly shaped with two lobes. So let's look at the diagram. So it is butterfly shaped with two lobes. So we have the left lobe and then the right lobe. If you look at it very well, you realize it looks like a butterfly. Okay, that's why we say it's butterfly shape. Okay, with two lobes, the left lobe and then the right lobe, joined by a narrow region or a narrow portion, okay, at the anterior medial part. Okay, good. So this is the narrowed portion, and the narrowed portion, we call it the isthmus. So it is butterfly shaped with two lobes and joined by a narrowed portion called the isthmus. So this medial portion, this narrow medial portion or region of the thyroid gland is referred to as the isthmus. Okay, so this is the anterior view of the thyroid gland. So you see the anterior view. This is the anterior view of the thyroid gland, and this is the posterior view of the thyroid gland. Okay, this is the anterior view, and this is the posterior view of the thyroid gland. So the anterior view, this is how it looks like. The posterior view, we have the parathyroid glands just behind the thyroid gland, the four parathyroid glands, okay, just behind the thyroid gland. Okay, good. So if you look at, so this is the trachea. So you realize that it is in front of the trachea, and this is the larynx. Okay, that's why we say anatomically it is below the larynx. Okay, so it is butterfly shaped with two lobes, the left lobe, the right lobe, joined by a narrowed portion of that same thyroid gland called the isthmus. Okay, and we mentioned it is located in front of the trachea or anterior to the trachea, just below the larynx. Okay, good. All right. Now, it consists of thyroid follicles lined by follicular epithelial cells that secrete the T3, that is the triiodothyronine, and T4, the tyrosine. Okay, and these are what we refer to as the thyroid hormones. So we have follicles in the thyroid gland. In fact, we have two follicles in the thyroid gland. Okay, so these are the two cells in the so we have the follicular cell that secretes the T3, which is the triiodothyronine, and then the T4, which is the tyrosine. Is that okay? Good. And then we have the parafollicular cells. These are the parafollicular cells. Okay, so we have basically two cells in the thyroid gland. Okay, the parafollicular cells. Okay, and then the follicular cells. So the follicular cells produce the T3 and then the T4. Okay, and these T3 and T4, these are the hormones that increase metabolic rate. These hormones also plays a role in oxygen consumption, thermogenesis, cardiovascular and respiratory activity, and they also promote growth and neurological development. The follicular cells produce the T3 and then the T4. These cells, this is the thyroid gland. This is the follicular cells. Okay, so the follicular cells produce the triiodothyronine, which is the T3, and then the tyrosine, which is the T4. And then we have the parafollicular cells. The parafollicular cells are the ones that produce the calcitonin. This hormone is responsible for lowering your blood calcium levels. It works to lower your blood calcium levels. So how many cells do we have in the thyroid gland? 2 cells. The follicular cells, okay, and then the parafollicular cells. You realize that the follicular cells dominate in the thyroid gland. We have a lot of follicular cells as compared to the parafollicular cells. Okay, good. And then we also mentioned that it uses a hormonal axis. This gland operates using a hormonal axis called the hypothalamic pituitary thyroid axis. And this hormonal axis uses the negative feedback mechanism. Okay, this is the axis. This is the axis. It uses this axis, hypothalamic pituitary thyroid axis. Now, in the hypothalamic pituitary thyroid axis, it is demonstrating the cycle of how the gland and its hormones, the hormones that it releases, the cycle within which it operates under the endocrine system. So you realize that for hypothalamic pituitary thyroid axis, the hypothalamus produces the thyrotropin releasing hormone. Okay, then the thyrotropin releasing hormone goes to the anterior pituitary or the pituitary and stimulates the thyrotroph cells in the anterior pituitary. Once the thyrotroph cells in the anterior pituitary are stimulated, is that okay? The thyrotroph cells produce the thyroid stimulating hormone. And the thyroid stimulating hormone comes to the thyroid gland, stimulates the thyroid gland, specifically the follicular cells of the thyroid gland, to produce the T3 and then the T4, and also stimulates the parafollicular cells to produce the calcitonin. Now, when the levels of T3 and T4 increases excessively in the blood, this increased level of T3 and T4 sends a negative signal, okay, to 1, the pituitary gland, and 2, the hypothalamus, so that they stop producing the thyrotropin. The hypothalamus stop producing the thyrotropin releasing hormone, and the anterior pituitary also stop producing the thyroid stimulating hormone. Okay, so you realize that is the axis, this hormonal axis is demonstrating the cycle of how the hormonal activity of the thyroid gland operates in the endocrine system. Okay, so it uses the hypothalamic pituitary thyroid axis. Okay, so in this axis, it starts from the hypothalamus. The hypothalamus produces the thyrotropin releasing hormone. Thyrotropin releasing hormone, when it gets to the anterior pituitary, specifically stimulates the thyrotroph cells. Then the thyrotroph cells produces thyroid stimulating hormone. The thyroid stimulating hormone circulates, reach the thyroid gland. The thyroid gland is highly vascularized. So it stimulates the thyroid gland, specifically the parafollicular cells and then the follicular cells in the thyroid gland, so that the follicular cells produce the T4, T3, parafollicular cells produce the calcitonin. Once the level of T4, T3 dominates, becomes excess in the blood, it sends a negative signal to the pituitary gland and also to the hypothalamus, so that the hypothalamus stop producing thyrotropin releasing hormone, and then the pituitary gland also stop producing the thyroid stimulating hormone. This is what we call the hypothalamic pituitary thyroid axis. Okay, so the thyroid gland basically works with this axis, okay, to control the levels of its hormone release. And so the axis makes use of negative feedback. As the levels increase, a signal is sent to the upper endocrine, okay, or higher centers, okay, for the hormone release to be inhibited. Is that okay? That's what we mean by negative feedback mechanism. Okay, good. Now, and the clinical significance of understanding the thyroid gland and its hormone release, including the hormonal axis, is that it will help you appreciate the role that each level plays. Okay, so that you appreciate the fact that someone can be having a problem with metabolism and it may be coming from the hypothalamus. So, for example, if something is happening at the level of the hypothalamus and the hypothalamus is hyper-secreting the thyrotropin releasing hormone, in this situation, the patient may not be having, there may not be a direct problem with the thyroid gland, but because the problem there is a problem at the hypothalamus, it can come a long way to come and affect the thyroid gland release or the secretions or the activities of the thyroid gland. Okay, then again, it will help you to also appreciate the fact that someone may be having a normal hypothalamus, someone may be having a normal thyroid gland, but the problem in the pituitary gland, okay, can lead to, because of the axis, because the thyroid gland does not just release its secretions under its own regulation or control. It's under the influence of the pituitary. The pituitary is also under the influence of the hypothalamus. Is that okay? Good. So that will help you. That's the clinical significance. That will help you to appreciate it better. Okay, so this is the largest endocrine gland. It weighs about 20 to 25 grams, highly vascularized, and it is located anterior to the trachea, just below. So it is located anterior in front of the trachea. So this is the trachea, and it is just below the larynx. It has two lobes, so the left lobe and then the right lobe, and they are joined by a narrow portion or region referred to as the isthmus. This is the isthmus. So this is the front view of the thyroid gland, and this is the posterior view. I mentioned that the posterior view, if you look at the posterior of the thyroid gland, you are going to see the parathyroid glands, the 4 parathyroid glands. Okay, and this is the thyroid gland. Okay, so the thyroid gland, we have 2 cells, the follicular cell and then the parafollicular cells. The follicular cells are the ones that produce the triiodothyronine T3, which is the active hormone, and then the tyrosine T4, which is the precursor hormone. Is that okay? Good. So basically, that is it for the thyroid gland. Now let's look at the mechanism of thyroid hormone synthesis. The mechanism of thyroid hormone synthesis. With the mechanism of thyroid hormone synthesis, we are looking at how the thyroid hormone is being released. Okay, how they are being produced in the thyroid gland and the mechanism it goes through for them to be released. Now, in fact, if you take in a food that contains iodine, okay, they are being absorbed into the blood in the form of iodide. Anytime you take in food containing iodine, they are being absorbed in the blood in the form of iodide. Okay, so the iodide is in the blood, they are circulating, and so they get to the thyroid gland. Okay, they get to the thyroid gland, and then eventually when they get to the thyroid gland, around the thyroid gland, okay, we have a channel that we call iodide sodium symporter or sodium iodide symporter. Is that okay? So the iodide passes through or make use of this channel, the sodium iodide symporter, and then finds its way into the follicular cell or into the follicular cell of the thyroid gland. Now, once the iodide have now entered the follicular cell of the thyroid gland, okay, we have an enzyme in the thyroid gland that we call the thyroid peroxidase, TPO, the thyroid peroxidase. This thyroid peroxidase help convert the iodide into iodine in the thyroid gland. Okay, it help convert the iodide into the iodide into iodine in the thyroid gland. Now, once we now have iodine in the thyroid gland, okay, already in the thyroid gland, we have a large protein in the thyroid gland. That's a large glycoprotein in the thyroid gland. We call it the thyroglobin. Okay, the thyroglobin is like a protein that contains the tyrosine residues. Is that okay? So the iodine now attaches itself to the thyroglobin. Okay, once it attaches itself to the thyroglobin, they form the monoiodotyrosine, which is the MIT, and then diiodotyrosine, okay, which is the DIT. Okay, now the next thing that will occur, we call it coupling of the iodotyrosines. Coupling. Is that okay? Now, the coupling happens in 2 forms. Okay, you see, we have monoiodotyrosine and then we have diiodotyrosine. Now, one of the monoiodotyrosine would combine with the diiodotyrosine to give us the T3, which is the triiodotyrosine. which is the T3. So T3 is MIT plus DIT. Then two of the diiodotyrosine will also combine to form the tyrosine, which is the T4. So T4 is DIT plus DIT. Is that okay? Then after this T3 and T4 has been formed, the next thing is there is going to be endocytosis of this T3 and T4 from the follicular cell. Is that okay? Then that means that hormone release has occurred. Okay, so first let's summarize it all over again. So I said that if you take in a food containing iodine, it is being absorbed into your blood in the form of iodide. Now the iodide is in the blood, is circulating. When it gets to the thyroid gland, it enters the thyroid gland. Now it's about to enter the follicular cell. Okay, around the follicular cell, we have a channel that we call iodide sodium symporter. So the iodide take advantage of this channel called the iodide sodium symporter and enters the follicular cell. Once it enters the follicular cell, we have an enzyme in the follicular cell called the TPO, the thyroid peroxidase. Okay, so this TPO help convert the iodide into iodine. Okay, then now we have iodine in the follicular cell. Now, already in the follicular cell, we have a large protein, a large glycoprotein in the follicular cell. We call it the thyroglobin. Then the iodine will bind with the thyroglobin to form the iodo. It will bind with it to form what we call the iodotyrosines. The iodotyrosines are in two forms. We have the monoiodotyrosine and then diiodotyrosine. Okay, the monoiodotyrosine is the MIT, and then the diiodotyrosine is the DIT. Now, after the iodotyrosines have been formed, then coupling would have to occur, okay, for us to now get the actual thyroid hormones, which is the T3 and T4. Now, during the coupling, one of the monoiodotyrosine would combine with the diiodotyrosine. Okay, so one meaning MIT plus DIT. Then we get the triiodotyrosine. Okay, sorry, triiodotyrosine. Triiodotyrosine. Okay, triiodotyrosine, meaning MIT plus DIT. Then one of the diiodotyrosine would combine with another diiodotyrosine, meaning two diiodotyrosines will combine, meaning DIT plus DIT. Okay, then that will give us the T4, which is the tyrosine. And these two hormones are actually the thyroid hormones, the T3 and then the T4. Okay, so we get them during the coupling of the iodotyrosines. Is that okay? Then now we have the T3 and T4. Then the next phase that will occur is the hormone release, which happens with the a mechanism or a process called exocytosis. Is that okay? So that the hormones are released out of them. The hormones are released out of them, the follicular cell into the bloodstream. Is that okay? So basically, that is it for this process. Okay, the process of thyroid hormone synthesis and secretion. Okay, so basically that is it. Now, in general, let's look at the clinical significance of the thyroid hormone anatomy. Okay, the thyroid gland anatomy, the thyroid hormone anatomy. Okay, now you know the thyroid hormone synthesis. If you look at the thyroid hormone synthesis, it relies on iodination of the thyroglobin by the follicular cells. Okay, so that should tell you that if you look at this process, okay, you realize that we have an enzyme. When you take in food containing iodine, it is absorbed as iodide. When it gets into the follicular cell, okay, it passes through the iodide sodium symporter, enters the follicular cell. The TPO, the thyroid peroxidase, which is the enzyme, have to convert it. The question is to ask yourself, okay, what if the person is not having a problem with the thyroid peroxidase? Okay, so that means that there wouldn't be proper. So someone may be okay with the amount of iodine the person is taking. May not be deficient in terms of consumption, but there can be problem with the TPO. Okay, so if you understand this, or if you understand all these things, it will help you to appreciate where thyroid problems may be coming from. So someone may be having a problem with metabolism. It may not be coming from the hypothalamus. It may not be coming from the pituitary. It may be coming from the chemical level. It may be coming from the thyroid peroxidase. Okay, it can also be a problem even with the thyroglobin, because you see, it's the thyroid peroxidase TPO that have to convert the iodide into iodine. So if the problem, the question is, what if the person is having a problem with the TPO? Okay, now when the TPO also converts the iodide into iodine, the iodine also have to combine, okay, with the thyroglobin before we get the iodotyrosines. What if the person is having a problem with the thyroglobin? What will happen? Meaning the thyroid hormones, okay, the iodotyrosines will not be produced. The two iodotyrosines, which is the MIT and the DIT, will not be produced. Okay, so it's very important that you understand the thyroid hormone, you know, all the thyroid hormones, and then how they are synthesized. Okay, it's very, very important that you understand the dynamics between all the thyroid hormones. Okay, good. So basically, that is what we are talking about. We have a condition that we call Graves' disease. Is that okay? We have a condition that we call Graves' disease. Now, another thing that you have to understand is that you realize that the thyroid hormones, they are two. We have the T3 and then the T4. Okay, the T3 is the triiodothyronine. The T4 is the tyrosine. Is that okay? So the thyroid hormones, basically, the two main thyroid hormones are the T3 and then the T4. We also have the calcitonin, but these are the two main. Okay, understand that the T3 is formed by 3 iodine atoms. It's 3 iodine atoms that actually forms the T3. Okay, and 4 iodine atoms forms the the T4. But the T3 is the active one. It's more active. Okay, this one is about 3 to 5 times more potent than this. That means this one, the T4, is less active. So this one is like a precursor. So it's like having enough battery on your phone. You've charged it, having enough battery. That is the T3. And then having a power bank, so that if this one goes down, this one will be broken down to get this, the T3. So this one is the less active form. It's like a storage. It's like a backup hormone to this one. Okay, so the T3 is the active one. The active one. Is that okay? So this is something that you have to know. Okay, now let's look at the clinical significance. The significance of understanding the thyroid hormone anatomy is that it will help you to appreciate certain conditions like hyperthyroidism. Example, Graves' disease. Okay, for example, if you understand the thyroid hormone anatomy, you would appreciate what will happen when someone is having excess amount of what? T3 and T4. Is that okay? So in this condition, for example, Graves' disease, in this condition, it's like someone is having high levels of the thyroid hormones, the T3 and then the T4. High levels of the thyroid hormones, the T3 and then the T4. That is what happens in this condition. Is that okay? And if someone is having high levels of T3 and T4, it tells you that the person can have conditions like hypertension, conditions like palpitation, tachycardia. You get it? Conditions like problems with GIT, like diarrhea, because digestion may not be proper. The person, because of the internal heat that will be generated because of metabolism, this person can have a high body temperature and may even experience what we call heat intolerance. The person may not be able to tolerate an environment that is very hot, because internally this person is having a high metabolic rate. So internally temperature is very high. Is that okay? Good. It will help you to appreciate some of these conditions. Okay. It will also help you to, your understanding of the hormonal axis that this gland works with, the hypothalamic pituitary thyroid axis. If you understand it, it will help you to appreciate where thyroid problems can come from, the various levels issues with thyroid may be coming from. Okay, so that you can clinically assess patients very well and even understand their conditions. Okay, and apart from that, thyroid blood supply and structure guide safe surgical procedures. We realize that when we started, I mentioned that we have a lot of blood vessels. The thyroid gland is highly vascularized, meaning we have a lot of blood vessels, including nerves, around the region where the thyroid gland is. And that can guide you to be very courteous when you are going to perform surgical procedures and know how to be very courteous to maneuver your way before you reach the thyroid gland because of how vascularized it is. It will also help you as a nurse to also appreciate the fact that after a thyroidectomy, patients have gone in for a surgery to remove the thyroid gland. You should be very careful to assess the patient very well because, in this situation, the thyroid gland is highly vascularized and we have nerves. For example, the laryngeal nerve is closer to the thyroid gland, which can be injured. Is that okay? It can be injured during a thyroidectomy. So you all have to assess patients for all these complications post-operatively. Is that okay? Good. So basically it will also help you to understand pharmacological measures relating to the thyroid gland and the hormones that it produces. Okay. For example, we have thyroid hormone analogs like the levothyroxine, and then we have the anti-thyroid drugs like the methimazole. You get it? This levothyroxine is like a synthetic form of the T3 and T4. Do you get it? So when we give a patient this, so usually if a patient goes in for thyroidectomy, we can give the patient the levothyroxine to go and replace the work that would have been done by the T3 and T4. Then we have the anti-thyroid drugs. Okay, anti-thyroid drugs. Anti-thyroid drugs like methimazole. So for example, a patient having high levels of T3 and T4. If a patient is having high levels of T3 and T4, then we will give the patient methimazole. It's an anti-thyroid medication. It will reduce the effects of T3 and T4. An anti-thyroid, or it will stop the production or the release of T3 and T4. Methimazole. Okay, and then levothyroxine is a thyroid hormone. Is that okay? So basically, that is it for the thyroid gland. So in a condition like Graves' disease, you see patients will experience exophthalmos, goiter, sweating, okay, good, because of the high metabolic rate. Okay, tachycardia will be present, nausea and diarrhea, oligomenorrhea, especially in females, muscle weakness and tremor. Because see, here we are talking about hyperthyroidism. So you can see signs like headache, weight loss, even though these patients will would have increased appetite, okay, but will still lose weight. And the reason is because the energy utilization in a patient with hyperthyroidism far exceeds the energy consumption, the food the person is taking in, okay, and then the energy the person's body is using is so high beyond the food that the person is consuming, or the energy the person derives from the foods that they are consuming. So we say that energy utilization is very high as compared to energy consumption in a patient with hyperthyroidism because of the increased metabolic rate. And this is the diagram showing the blood vessels and then the nerves that are related to the thyroid gland. So you can see we have a lot of nerves. The yellow ones are representing the nerves. So you have nerves closer to the thyroid gland. So you see the laryngeal nerve. This is the laryngeal nerve. Okay, so if a patient comes back from thyroidectomy surgery, you should observe the patient for possible complications of some of these nerves or some of these related structures like the blood vessels. Observe patient for signs of bleeding, signs of shock. Is that okay? Because of the blood vessels and the nerves that are associated with or that are very close to this gland. Is that okay? Good. So basically that is it for the thyroid gland. The thyroid gland is the largest gland, weighing about 20 to 25 grams, highly vascularized and located anterior to the trachea, just below the larynx, spanning the levels of the fifth cervical vertebrae and then the first thoracic vertebrae. Okay, we also call this gland the gland of metabolism. This is the gland in charge of metabolism. So if activities of this gland increases, your metabolic rate would also increase. Okay, good. That should tell you if your metabolic rate increases, internal temperature would increase. because of the increased metabolic rate, and you may not be able to tolerate or cope in a very high temperate area or environment. Is that okay? This gland is responsible for cardiovascular and respiratory activity. So if activity of this gland increases, there can be signs like palpitation, signs like tachycardia. Do you get it? Good. So basically, that is it for the thyroid gland. Remember that in the thyroid gland, we have two cells, the follicular cells and then the parafollicular cells. The follicular cells actually produce the thyroid hormones, which are the triiodothyronine, the T3, and then the tyrosine, the T4. And then the parafollicular cells are the ones that produce the calcitonin, which works to lower your blood calcium level. Calcitonin, which works to lower your blood calcium level. This gland make use of an axis or a hormonal axis called the hypothalamic pituitary thyroid axis, and these axes operate using the negative feedback mechanism. All right, thank you so much. This brings us to the end of the video or the session on the thyroid gland anatomy and physiology. Kindly subscribe to the channel, click on the like button, and do well to share this content to a friend. Thank you so much. All the best.